To conclude these talks about heart diseases, here we have a table that summarizes everything I have discussed about the 5 conotruncal heart diseases. We should say that all conotruncal heart defects, except corrected transposition of the great arteries, have a normal 4-chamber view, and corrected transposition of the great arteries has an abnormal 4-chamber view. That is the guiding point in the corrected transposition of the great arteries. In contrast, transposition of the great arteries, Tetralogy of Fallot, Truncus Arteriosus, and double outlet right ventricle generally have a normal 4-chamber view, while corrected transposition has an abnormal 4-chamber view, and that is how the diagnosis of corrected transposition is made. The 5-chamber view will be abnormal in transposition of the great arteries and in Tetralogy of Fallot. In Truncus Arteriosus, there will be a malaligned VSD, and in double outlet, there will be a malaligned communication. Also, in transposition of the great arteries, the 5-chamber view is abnormal. There is a ventricular septal defect in transposition of the great arteries. In simple transposition, there is no defect. In complex transposition of the great arteries, there may be a defect. There is a ventricular septal defect. In the others, in Tetralogy of Fallot, there is a subaortic defect. In double outlet right ventricle, there is a subvalvular defect. In truncus, in double outlet, there is a subvalvular defect which can be aortic or pulmonary. And in congenitally corrected transposition of the great arteries, if it is simple, there is no defect, and if it is complex, there is a defect. The 3-vessel trachea view is altered. In transposition of the great arteries, there are only 2 vessels. In Tetralogy of Fallot, the 3-vessel trachea view is abnormal because the diameter of the pulmonary artery is reduced. In Truncus Arteriosus, there will be 2 vessels, and in double outlet right ventricle, it is also altered depending on what type of double outlet it is. And in corrected transposition, there will also be 2 vessels in the 3-vessel trachea view. Chromosomal abnormalities. In TGA, there are none, and in the others, in Tetralogy of Fallot, it is associated with a 22q11 deletion and with trisomies. In Truncus Arteriosus, it is associated with trisomies 13+18 and 22q11. In double outlet right ventricle, it is also associated with trisomies. And in the corrected form, just like in simple transposition, it is not associated with chromosomal abnormalities. Associated heart defects may be present. In arterial transposition, there may be a ventricular septal defect. In Tetralogy of Fallot, there may be an aberrant right subclavian artery and a right-sided aortic arch. In Truncus Arteriosus, there may be interruption of the aortic arch. In double outlet right ventricle, there may be pulmonary stenosis and there may be aortic stenosis. In congenitally corrected transposition of the great arteries, associated heart defects may include a ventricular septal defect, an Epstein anomaly, and complete atrioventricular block. Extracardiac anomalies in transposition are very rare in Tetralogy of Fallot and Truncus Arteriosus CNS and urogenital anomalies. In DORV, central nervous system, gastrointestinal, and musculoskeletal anomalies, and in congenitally corrected transposition of the great arteries, extracardiac anomalies are very rare. In simple transposition of the great arteries, the surgery is generally corrective. In Fallot-type pulmonary artery stenosis, as we mentioned earlier, it is corrective. In Truncus Arteriosus, it is also a corrective surgery, and in double outlet right ventricle, it may be corrective as well. However, in complicated cases, it will be a palliative surgery. In the case of congenitally corrected transposition of the great arteries, if it is a simple congenitally corrected transposition, it does not require early surgical treatment during the first year of life. Only serial follow-up evaluations are performed. This is as long as there is no atrioventricular block, which would require a pacemaker, and also as long as there is no stenosis of the semilunar valves, whether pulmonary or aortic. Transposition of the great arteries has a good prognosis, with survival above 90%. The prognosis for Tetralogy of Fallot is 97%. Truncus Arteriosus decreases to 86%. Double outlet right ventricle fluctuates around 90%. And simple congenitally corrected transposition of the great arteries has a good prognosis of 95%. To wrap up, here we are going to list the 5 conotruncal heart diseases. Transposition of the great arteries, the least often diagnosed and the most difficult, because it is not associated with any chromosomal abnormality, and only very rarely with extracardiac abnormalities. Double outlet right ventricle, Truncus Arteriosus, and the Tetralogy of Fallot complex. All 4 have a normal 4-chamber view, and therefore their diagnosis must be made using the outflow tracts and the 3-vessel trachea view. Therefore, the recommendation is to always perform the 5 Yagel views so that no conotruncal heart disease is missed. Corrected transposition of the great arteries will be diagnosed using the 4-chamber view, which will be an altered 4-chamber view. As in this case, there is double atrioventricular discordance and ventricular arterial discordance. And here we see 2 cases where the 4-chamber view is abnormal because there is an atrioventricular discordance. Thank you very much. And I hope that with this talk, we will always be able to diagnose a conotruncal fetal heart defect, or at least suspect it, on the 22-24 week ultrasound or at any time during the pregnancy.